بيكفر.
انا هحاول نعمل سمرايز كده سريع يعني،
اوكي ماشي.
ممكن بس المانجمنت هو اللي نخوض فيه ديتيلز
خلاص
شويه،
تقدر
لكن
تقدر تبدا يا دكتور احمد. دكتور احمد طبعا اخصائي اول emergency medicine مستشفى أملك. اتفضل يا دكتور أحمد.
اولا انا سعيد جدا باتاحه الفرصه دي ان احنا نتشارك في بعض المعلومات يعني. هي في النهايه مجرد تذكير مش اكتر، احنا كلنا عندنا النولج، بس هي مجرد تذكير. آه، نبدا. In this lecture we will talk about management of diabetic emergencies according to latest guidelines ADA standard. Uh, uh, at the end of the lecture, we will cover the three most critical diabetic emergencies: DKA, diabetic ketoacidosis, hyperosmotic hyperglycemic state (HHS), and severe hypoglycemia. تمام الصوت يا دكتور هيثم واضح ولا ايه؟
كلير يا دكتور أحمد كلير.
اوكي. introduction بسيطة كده. DKA الهايبرجلايسيميك كرايسيس، DKA and HHS. DKA and HHS represents two ends of the spectrum of severe decompensated diabetes. DKA is characterized by absolute insulin deficiency leading to ketoacidosis. HHS is characterized by relative insulin deficiency that is enough to prevent significant ketogenesis but insufficient to prevent severe hyperglycemia that leading to osmotic diuresis and profound dehydration. When we talk about hyperglycemic crisis, we should search for the underlying triggers and causes. For this, we use I mnemonic. I for infection. This is one of the most common causing. Pneumonia, UTI maybe. Second, I for insulin. Patient is not compliant to treatment. Missed doses maybe. Pump failure if the patient doesn't pump. Third I is for ischemia and infarction. Maybe myocardial infarction, stroke, mesenteric ischemia. I for intoxication, like alcohol and the drugs. Another I is iatrogenic, like SGLT2 inhibitor use, and also
صح اخذ منك العلامات الحيويه. سموه التحليل التنوعي. العلامات الحيويه اخذ منك الضغط والسكري. الضغط والسكري.
في صوت حد بيتكلم دكتور هيثم.
كونتينيو دكتور أحمد.
تمام اوكي. Okay, let's go for pathophysiology. To summarize pathophysiology, DKA is defined by an absolute or near absolute shortage of active insulin, coupled by elevated counter-regulatory hormone. These cause to activate hormone-sensitive lipase in adipose tissue, leading to lipolysis and the release of free fatty acids that migrate to liver, where they undergo beta oxidation and converting into ketones bodies, acetoacetate, acetone, and the primary beta hydroxybutyrate. The accumulation of these three organic acids consumes the bicarbonates and start causing wide anion gap metabolic acidosis. طيب لو جينا على الكلينيكال ساينس هنلاقي ان الدي كي اي characterized by acute onset. Manifestations include polyuria, polydipsia, weight loss, nausea, vomiting, generalized abdominal pain due to delayed gastric emptying and acidosis, deep rapid breathing attempting to respiratory compensation for metabolic acidosis. On another side, HHS is marked by relative insulin insufficiency combined by extreme fluid loss. The trace amount of insulin is sufficient to inhibit lipolysis and subsequent ketogenesis, prevent severe ketoacidosis, however, inadequate to facilitate peripheral tissue glucose uptake. This leading to extreme hyperglycemia and driving extracellular osmolality to upward and pulling intracellular fluid into the intravascular compartment, causing profound cellular dehydration. Clinical signs develop gradually, maybe over days or weeks. Presentation is marked by profound hydration, dehydration, severe hypotension, tachycardia, and neurological impairment, altered mental status varying from lethargy to coma. This is related to the degree of hyperosmolality. Focal neurological deficit or generalized seizures may be also present in these patients. Okay. Now for diagnostic criteria. Diagnostic criteria, we will divide DKA into mild. هناك. We will divide DKA into mild. Sorry for interruption. DKA, we will divide DKA into mild, moderate, severe. Mild plasma glucose is over 250. pH is from 725 to 730. Serum bicarb is from 15 to 18. Ketones in serum and urine positive. Osmolarity variable. Anion gap is more than 10. Patient is alert. For moderate DKA, also plasma glucose is over 250. pH is from 7.0 to 7.24. Serum bicarb is from 10 to 15. Of course, serum ketones and urine ketone will be positive. Anion gap is more than 12. Severe DKA, pH will be less than 7. Serum bicarb will be less than 10. And anion gap is more than 12. Patient may be tuber or comatose. For HHS, diagnostic criteria, plasma glucose usually more than 600. pH is more than 7.30. Serum bicarb is more than 18. Ketones minimal or absent. Osmolarity is more than 320. Anion gap variable may be normal. Patient has focal neurological deficit, may be coma, stupor, like this. There is one note here. We should take care of euglycemic DKA. Present with an overall diagnostic triad of DKA, like acidosis and ketonemia, but plasma glucose is below 250. And this is increasingly observed in patients using sodium glucose transporter 2 inhibitor, and the pregnant individuals, or patients facing profound caloric deprivation. Now we'll go for advanced protocols for hyperglycemic crisis. We will go in deep in this part of the lecture. We have 4 important steps. We have 4 important steps in management of hyperglycemic crisis. Almost the same. HHS and DKA are almost follow the same protocol for treatment with some adjustment. First, fluid resuscitation and the intravascular volume titration. Resuscitation must proceed along systemic phase-driven endpoint to optimize intravascular volume while guarding against tissue edema. We will divide this part into 3 phases. Okay. Phase 1, emergency intravascular resuscitation. This in first out. The primary goal is rapid stabilization of hemodynamic parameter and restoration of renal blood flow using balanced crystalloid, like lactated ringer, as the primary fluid medium. In the modern trials, confirm balanced solution significantly reduce hypercoloric metabolic acidosis risk compared to normal saline, shortening overall the time to DKA resolution. We will run at rate of 15 to 20 milligram per kg per hour, around 1,000 and 1,500 ml per hour. For patient with underlying history of congestive heart failure or end-stage renal disease, we will reduce this initial phase down to 250 to 500 ml per hour with close hemodynamic monitoring. دكتور هيثم، لو في اي حد عنده مش متابعني ممكن يوقفني في اي لحظه
حد عنده أي سؤال any question or any يعني أي استفسار معاكم دكتور أحمد يا شباب.
Phase 2, we will manage according to the corrected sodium driven volume maintenance. Following the initial fluid volume optimization, we will evaluate the patient for calculating of corrected sodium using this clinical formula. Corrected sodium equal measured sodium plus 0.016 في serum glucose minus 100. أنا هحاول أشير لكم المعادلة عشان تبقى واضحة، بس للأسف هي مش موجودة في المحاضرة، نسيت أضيفها للمحاضرة. نقولها تاني. corrected sodium equal measured sodium. Any question? Measured sodium plus 0.016 multiplied by serum glucose minus 100. And we will manage according the result. Infuse fluid during this stage with controlled maintenance rate of 250 to 500 ml per hour. According to the corrected sodium, we will select the compound. If corrected sodium is normal or high, more than 135, we will go for hypotonic saline to support intracellular hydration. If corrected sodium is below 135, we will maintain fluid support using isotonic fluid اللي هو النورمال saline or balanced crystalloid lactate ring. Clear? Everything is clear like this till now?
Yes, clear دكتور أحمد.
Phase 3 is the prevention of hypoglycemia. The dextrose co-infusion strategy. Okay, what we call is dextrose switch. As insulin action clears circulating ketones and reduce serum glucose, secondary fluid-like containing dextrose must be systemically introduced to ensure continuous delivery of the insulin infusion without precipitating iatrogenic hypoglycemia or cerebral edema. In DKA, when plasma glucose concentration reach 200 to 250, add 5% to 10% dextrose, D5 or D10, changing fluid to D5 half normal alkaline at 250 to 500 ml per hour. In HHS, due to extreme plasma hyperosmolarity, we should introduce glucose earlier. Once plasma glucose drop below 300, we will start the same strategy. There is another phase especially to this related to this phase, which is osmotic safety parameter, the speed limits. We shouldn't correct rapidly. We should use limit reduction. Overlay rapid correction of plasma glucose or osmolarity, precipitate fluid shift into the brain, leading to fatal cerebral edema. So we need to titrate according to maximum plasma glucose decline, limit reduction to 90 to 120 mg per deciliter per hour. Maximum plasma glucose decline, limit reduction to 90 or 120 mg per deciliter per hour. Maximum serum osmolarity decline, limit the reduction to 3 to 8 milliosmolar per kg per hour. Maximum serum sodium decline, limit total drop to less than 10 milliequivalent per liter per hour. So this is the first step in the management of hyperglycemic crisis, fluid resuscitation and the intravascular volume titration. Any question about this step?
Dr. Ahmed, the slide is fixed on a slide of dextrose switch. So this is from our side, or
I think there is a problem. I'm trying to.
because you are not, yes, you are not seeing what you are talking about. Yes. Now slide correction of potassium.
Actually, I summarized the presentation.
Okay.
Just to focus on the main points. Okay. Now we will go for potassium correction rule. Okay, potassium correction rule. This is the second step in the management of hyperglycemic crisis. Osmotic diuresis drives substantial whole body potassium depletion. Although initial serum labs may appear normal or falsely elevated due to extracellular shift from severe acidosis, the introduction of insulin therapy will rapidly drive potassium back into cells, predisposing the patient to cardiac arrest from hypokalemia. We will manage according to these strict laboratory markers. Okay, if serum potassium is below 3.3 milliequivalent per liter, absolute contraindication to insulin initiation. This is an absolute contraindication to insulin initiation. Hold insulin therapy, administer IV potassium chloride at 20 to 30 milliequivalent per hour until serum potassium safely exceeds 3.3. Okay? If serum potassium is between 3.3 to 5.2, we will add 20 to 30 milliequivalent of potassium chloride to every liter of infusing intravenous fluid to safely target a stable potassium range between 4.5 to 5 milliequivalent per liter. If serum potassium is 5.2, we will hold active potassium replacement and re-evaluate laboratory serum levels closely every 2 hours. Okay? Step number 3 is the correction of hyperglycemia intravenous insulin use infusion protocol. We will administer regular human insulin via a continuous calibrated electronic controller. Initiate the standard continuous infusion at rate of 0.1 unit per kg per hour, or give 0.1 unit per kg bolus followed by 0.1 unit per kg per hour, and we will monitor capillary glucose hourly. If initial drop in the first hour don't achieve 10% reduction, check the line patency and the correction integrity and the connection integrity, or double the active hourly infusion rate. This is the same, no changes in this guideline. So to sum up the management of hyperglycemic crisis, we will have 4 steps. Okay, first step is fluid resuscitation and intravascular volume titration. In this step, we use balanced crystalloid in the first hour at rate 50 to 20 milli per kg per hour, and for patients with underlying history of congestive heart failure or end-stage renal disease, we will reduce the initial phase down to 250 to 500 ml per hour. In the second hour to fourth hour, we will correct using sodium-driven volume maintenance. We will calculate the corrected sodium and we will manage according to the result. Okay. Phase 3, we will use dextrose co-infusion strategy to prevent iatrogenic hypoglycemia. In DKA, once the glucose reaches below 200 to 250, we will add dextrose. In HHS, due to extreme hyperosmolarity, when glucose concentration drop below 300, we will add dextrose. And we will take care of osmotic safety parameters. Maximum plasma glucose decline, we will limit the reduction to 90 to 120 mg per deciliter per hour. Maximum serum osmolarity decline, we will limit this to 3 to 8 milliosmol per kg per hour. Maximum serum sodium decline limit total drop to below 10 milliequivalent per liter per 24 hours. Okay, and we will correct potassium. It is early electrolyte optimization, potassium correction rule. Serum potassium below 3.3 is absolute contraindication to insulin initiation. We will add IV potassium chloride at 20 to 30 milliequivalent per hour until serum potassium safely exceeds 3.3. If serum potassium is between 3.3 and 5.2, we will add 20 to 30 milliequivalent of potassium chloride to every liter of infusing intravenous fluid to safely target stable potassium between 4 and 5. If serum potassium is more than 5.2, we will hold active potassium and re-evaluate every 2 hours. Third phase, we will use insulin infusion protocol, 0.1 unit per kg per hour, and monitor capillary glucose hourly. If initial drop in the first hour doesn't achieve 10% reduction, we will first check the line patency and the connection integrity, and then double the active hourly infusion rate. Okay, we said that we have 4 steps. Where is the 4th step? The 4th step is criteria of metabolic resolution or transition phases. We will never discontinue insulin infusion. We will never discontinue insulin infusion based only on glucose normalization. Resolution depends on the correction of the underlying metabolic state. DKA resolution criteria: if plasma glucose is below 200 milligram per deciliter, accompanied by at least 2 of the following markers. Venous pH is more than 7.30. Serum bicarbonate is more than or equal to 15 milliequivalent per liter, or a calculated serum anion gap is less than 12. HH's resolution criteria: serum osmolarity drop below 310 milliosmol per kg, blood glucose is lower than or equal to 250 milligram per deciliter, and the patient demonstrate recovery of baseline mental states. We use transition protocol. We'll administer subcutaneous basal insulin exactly 2 hours prior to terminating the continuous intravenous insulin infusion to avoid rapid rebound ketosis or hyperglycemia. Any question about hyperglycemic crisis, Dr. Haytham?
Thank you, Dr. Ahmed, for this updated lecture and good summary. لو حد عنده أي سؤال يا
No,
شباب.
we still have
يس
another
يس
part,
I
but
know I know. حد عنده أي سؤال أي استفسار في الجزء اللي فات؟ feel free to ask يا شباب. اوكي اتفضل يا دكتور.
we will talk about rapidly about hypoglycemia. Okay. The American Diabetes Association divided hypoglycemia into 3 main categories. Level 1 is sorry تمام السلايد ظهرت معاك ظاهره كده تمام.
Now slide of severe hypoglycemia.
Okay. This is the main core of emergency, but we will talk about the 3 levels of hypoglycemia. Level 1, patient plasma glucose is less than 70, but the patient is alert, unconscious. Level 2, plasma glucose is less than 54 milligram per deciliter. And this level is low enough to cause neuroglycopenic symptoms and represent a high risk of impending cognitive impairment and cardiac arrhythmias. Level 3 is severe hyperglycemia with severe cognitive impairment requiring external assistance for recovery regardless of exact plasma glucose reading. Okay. We will go step by step for management. Okay. First, clinical presentation divided into autonomic like tremors, palpitation, and anxiety, sweating, hunger, neuroglycopenic, dizziness, confusion, and behavioral changes, seizure, and coma. We already talked about it. Step-by-step management protocols. Protocol A, if the patient is conscious, patient level A, level 1, or level 2, and the patient is conscious. If the patient is awake, alert, and has safe, intact airway, we will apply rule of 15. First, we will administer fast-acting carbohydrates. We will give 15 to 20 gram of simple oral carbohydrates. Oral absorption is rapid, but we will avoid fats or protein like chocolate or milk at this stage, as they delay gastric emptying. Excellent clinical choice include 120 ml of fruit juice or regular non-diet soda, or 3 to 4 commercial glucose tablets. And we will rest and wait. Have the patient sit quietly for 15 minutes to allow the glucose to enter the bloodstream. We will recheck capillary blood glucose and perform finger stick check after 15 minutes. If glucose is still less than 70 milligram per deciliter, we will repeat step 1. Okay. If glucose is normalized, provide a standard snack or meal containing complex carbohydrates and the protein source. تمام؟ واضح كده؟ خلاص يبقى المريض conscious, alert, intact airway. عندنا rule of 15. Administer fast-acting carbohydrates, give 15 to 20 grams of simple oral carbohydrates, like fruit juice or regular non-diet soda. We will rest and wait for 15 minutes. After 15 minutes, we will recheck. If glucose is still below 70 milligram per deciliter, we'll repeat this step again. If glucose is normalized, we will provide a standard snack with complex carbohydrates and protein source. Protocol B for the unconscious or incapable patient, اللي هو level 3. If the patient is experiencing level 3 emergency, with confusion, seizures, coma, where oral intake may cause severe aspiration risk, we will immediately introduce vascular access. With established intravenous access, we will administer 25 grams of D50 dextrose or 250 ml of D10 over 2 to 3 minutes. And will flush the line slowly as concentrated dextrose is highly hypertonic. And we will check blood glucose within 15 minutes. If it remains low, we will repeat with partial boluses or initiate continuous infusion of D10 or D5 dextrose to maintain blood glucose securely above 100. Okay, again, if we have IV access, okay, we will give 25 grams of D50 or 250 ml of D10. Recheck blood glucose within 50 over 2 to 3 minutes, okay, and we check blood glucose. If it remains low, we will repeat with partial boluses or initiate a continuous infusion of D5 or D10 to maintain blood glucose above 100. Okay, if we don't have an IV access, what will we do? Okay, intramuscular or subcutaneous track, administer glucagon 1 mg via deep intramuscular injection, typically into deltoid, okay, or subcutaneously. Immediately turn the patient into their side in the recovery position because glucagon frequently induce vomiting once administered. Secure IV line early while the glucagon take effect, maybe take 10 to 15 minutes. As soon as patient regain consciousness and can swallow safely, transition them to oral fast-acting carbohydrate following by long-acting food. Okay. Again, if we don't have IV access, we will use intramuscular or subcutaneous track. We will administer glucagon via deep intramuscular IM injection, typically into the deltoid, okay, or subcutaneous. And we reposition the patient into recovery position because glucagon may induce vomiting and causing aspiration. We will try to secure IV line quickly while glucagon take effect from 10 to 15 minutes. As soon as the patient regain conscious and can swallow safely, we will transition them to oral fast-acting carbohydrates, followed by long-acting food. Clear كده تمام clear.
Yes, Dr. Ahmad, this is very important point actually because some patient come hypoglycemic.
Any question till now?
Yeah, yes. This is very important because some of patients come hypoglycemic, and actually we have glucagon available in our hospital. So if there is difficult IV line, we can rapidly start with glucagon intramuscular. Yes.
I have only something left, one thing about hypoglycemia. I think I didn't put in the the EDA added a new guidelines to prevent or as a prophylactic to this patient who is liable to hypoglycemia. There is now a grade A recommendation that glucagon may be prescribed to all individuals taking insulin or these at risk of hypoglycemia. Okay, and there is a technology, continuous glucose monitoring, is now eligible, is expanded to all patients on insulin and non-insulin therapies with hypoglycemic risk. تمام، دول نقطتين جداد في الاي دي اي ان هم عايزين الجلوكاجون. Now grade A recommendation can be prescribed to all individual taking insulin or these at high risk of hypoglycemia. Continuous glucose monitoring is now eligible, expanded to all patients on insulin and non-insulin therapy with hypoglycemic risk. Now, to summarize, management of diabetic emergencies require methodological protocol-driven approach. For DKA and HHS, ensure adequate fluid volume and check potassium before starting insulin. Treat the ketosis, not just the glucose. For hypoglycemic, rapid recognition and intervention save lives. Use continuous glucosing monitoring is better. Any question?
في أي سؤال يا دكاترة لدكتور أحمد؟ Any questions؟
Any questions?
أي سؤال؟
شكرا جزيلا دكتور هيثم، شكرا لإتاحة الفرصة الجميلة دي. احنا يعني نراجع شيء زي ده سوا، وأتمنى الناس تكون استفادت حاجة أو طلعت بمعلومة جديدة من المحاضرة. إن شاء الله نلتقي في محاضرات أخرى إن شاء الله يعني.
شكرا دكتور أحمد، الحقيقة محاضرة جميلة جدا و updated summarized و to the point. بنشكرك، واحنا ان شاء الله بصدد ان احنا زي ما الزملاء عارفين احنا تم اعتمادنا من البورد السعودي، وان شاء الله قريبا كمان البورد العربي. فبالتالي احنا يعني بنشجع الجميع ان هو يشارك معانا سواء في التيتشنج، في الكيس برزنتيشن، في الهاندز اون تريننج. عايزين كمان حابين ان شاء الله نعمل زي هاند بوك، emergency هاند بوك يكون updated clinical approach، عشان يكون في ستاندرد كلنا ماشيين عليه. بنشكرك يا دكتور احمد. المحاضرة هتكون طبعا ريكوردد، وهنرفعها لكم باذن
تمام
الله
أكيد.
على اليوتيوب تشانل، بحيث اي حد عايز يرجع لها تاني. دكتور احمد لو تقدر تشير معانا برضو الPDF او الباوربوينت فور ريفيجن، نكون شاكرين.
الباوربوينت أوكي تمام.
نكون
تمام،
شاكرين جدا ليك يا دكتور
مفيش
احمد. شكرا
مشكلة.
شكرا.
العفو، شكرا جزيلا، شكرا لحضرتك، شكرا.